So before we get started with our conversation for tonight, I'm going to kick it to Adela to talk a little bit more about us. So thank you, Adela. You go ahead.
Hi, thank you, Isabel, and thank you, everyone. My name's Adela. My pronouns are she, her, hers, and I'm the government relations intern at Population Connection. Today, I'm super glad to be here to briefly introduce our organization and our Fight for Her campaign. So this campaign was started by Population Connection Action Fund to mobilize actions against attempts to reduce access to safe, affordable, appropriate, and comprehensive reproductive health care around the globe. We're currently the only group that's doing the on-the-ground grassroots activism to repeal devastating policies like the global gag rule and the Helms Amendment. Just for y'all's information, the global gag rule pretty much blocked US federal funding for non-governmental organizations that provided abortion counseling. Can y'all mute yourself, please? Yeah, we appreciate that. To continue, and then the second law that I just mentioned, the very long-standing Helms Amendment, restricting foreign assistance action funds to provide safe abortion services as a method of family planning. So both of them block international abortion and women's freedom of choice. Since the establishment of our campaign in 2017, we've had the pleasure to engage over 65,000 activists. Our news update is actually from last night, when the US House passed the fiscal year 2022 State Department of Foreign Operations Appropriations Bill. This bill is an enormous step forward in expanding access to reproductive health care, comprehensive reproductive health and family planning, as well as efforts to engage everyone. It includes a provision taken from the Global Health, Empowerment and Rights Act that will prevent a future president from unilaterally reinstating the global gag rule. This Global HER Act is where our title, HER Summit, come from. It also provides a total of $830 million for international family planning programs, with around $70 million directed to the United Nations Population Fund, or the UNFPA. This represents the first funding increase for the program in more than a decade. And finally, this bill no longer includes the Helms Amendment that I just mentioned above. So great job, everyone. Such a big win for our campaign. And thank you all for all the volunteers, partners, supporters, and for all the work we did during the week of action to end the global gag rule. Next, you're going to hear from our keynote speakers and our guest speakers during our breakout sessions, but please make sure you stay tuned to hear how you can take actions first. I'll kick it over to Colette, one of our brilliant, some of her lead fellows, to share our first action of the night.
Hi, everyone. I'm Colette. I use they, them pronouns, and I would like everyone to please take a moment to email your your members of Congress, particularly your senators, where we have a more uphill battle to passing the Global HER Act, and to remind them how important it is that they fiercely advocate for reproductive rights and health by supporting and co-sponsoring the Global HER Act. You can do so by clicking the link that we've just dropped in the chat. This is a quick and easy way to help put an end to the global gag rule. Thank you, everyone.
Thank you so much, Colette. We're gonna give everyone 1 or 2 minutes to try to open the link and send a very quick email just to make sure that the action is working. Perfect. If you have any questions, you can drop in the chat box. If not, we'll go ahead to move to the next session. So thank you, Colette, and thank you, everyone. Now we're gonna move to our keynote speech. We're super thrilled to be joined by Representative Ami Bera, who has represented California's 7th Congressional District in the US House of Representatives since 2013. Before I introduce him, I would love to encourage our audiences to raise questions for Representative Bera in the Zoom chat box. We are still not sure if he is voting for the appropriations bill, but if he's not, he would join us with a Q&A session. So please feel free to raise your questions. We will collect them and go over them in the end of the session. After 20 years of his medical career, Representative Bera works currently as the member of House Foreign Affairs Committee, where he serves as chairman of the subcommittee on Asia, the Pacific, Central Asia, and non-proliferation. He's also a senior member on the House Committee on Science, Space, and Technology, and the Vice Chair for Outreach for the New Democrat Coalition. Representative Bera has consistently opposed reckless legislations to limit women's personal reproductive healthcare choices. He has also tried very hard to ensure greater access to family planning and initiated a series of actions and bills to fight for gender equality. In the meantime, Lauren, can you stop sharing your screen and show the video that Rivera just sent us?
So Monica, if you want to go ahead, sorry, I did not mean to put you on the spot. Monica, are you able to share the action?
I can just share it out for everyone. If Monica's having technical difficulties, I can clearly relate to that in the current moment. So a couple of weeks ago, we wrapped up the week of action to end the global gag rule with a video that the extremely harmful impacts of the global gag rule and reminds us all of why we are here in the fight for her. We've shared this video out on Twitter and are asking that you all take part in this action by retweeting the video. So one of my colleagues is going to drop the link to the tweet in the chat box right now. And if you want to find it on YouTube, you can also click the link to Twitter and watch it on YouTube. There are a couple different ways to watch it. And it would be great for you to retweet this so that we can share this with our grassroots network, show our power, get more people engaged, and really uplift the voices of those who are most impacted by this policy. So if everyone can take about 30 seconds right now to retweet that, that would be really great.
I've dropped the link in the chat, so you should be able to access the tweet there. And if you don't have Twitter and you just want to use YouTube instead, you can find it easily on YouTube and send it to all of your networks. It's a super informative video, and I think really helps to get more people engaged. So thank you for sharing that, Lauren. Awesome. Okay, we will keep moving then. Thank you for bearing with us with the technical difficulties. I know it's been unfortunately over a year on Zoom, but I'm still trying to figure out how things work. So I totally feel you, Lauren. But we are going to move into our speaker sessions. The first session is we're going to be hearing from Dr. Gladys Kalema-Zikusoka, the founder and CEO of Conservation Through Public Health. And she will be speaking to the intersection of population health and the environment. And we're super lucky to have her here tonight with us. So we're very excited for her to be here. We're also super excited for session 2, which will be hosted by Dr. Michelle Dubón, the medical director at WINGS Guatemala. And here we're going to have the opportunity to learn more about community organizing and what reproductive health and rights activism looks like in our communities. So we're going to move right into Gladys's session right now, the first session on population health and environment. And Gladys, if you are able to share your screen for your presentation, we can get going.
Isabel, actually, can you move to session 2 first, as Dr. Gladys is having some trouble with her Zoom link?
Definitely. Okay, so we are starting with session 2, reproductive rights activism in your community, looking at how you can be a better activist and really fight to help pass the Global Her Act and make more of a difference in reproductive health and rights. So we're going to be starting with Michelle Dubón. Thank you so much for being here with us tonight, Michelle.
Hi, everybody. Thank you for the opportunity. So to start, if I want to share how we work in activism, I want to share with you, first of all, what do we do in WINGS? So sorry for my bad English, I'm doing my best. So what is WINGS? WINGS is an NGO, a nonprofit in Guatemala, who was, it started 20 years ago with an American, Sue Patterson, who is amazing. She loved Guatemala and she came here to live, and somebody came to her and tell her that there was 3 very poor women that needed access to surgery because they didn't want to have more kids. So she talked to some friends, and we started like that, just like a friend thing, like a community that right now we serve about 25,000 people a year. So every little step counts. And here's where we can see that every speak that we have, every talk that we have, every little effort that we do can change the world. So have changed Guatemala. What do? We try to provide services, quality services, especially to the people that with more need and that they don't have access. So I always said to my doctors and my nurses in WINGS, people don't have it's not their fault that they don't have money to pay for a great hospital and a great service. They should have the same service in their communities, in their languages, in the safety of their communities, and they shouldn't travel 6-7 hours to get an IUD, for example. They should have it in their community, and that's what we do. What happens in Guatemala? Why Guatemala? Because 75% of our population lives in extreme poverty or extreme poverty, and most of them are indigenous people. Up to 80 or 90% of indigenous population live in extreme poverty, and they don't have even money to eat. They have more children, so the average of how many kids every woman have, it's 3.1, but in indigenous communities is 3.7. So I have traveled to a lot of communities very far away, and we've seen women with 18 kids, 15 kids. It's very common to see things like this. And half of our children are malnourished. They have malnutrition. This is very interesting fact, and we should be ashamed of. Guatemalan women are the smallest women in the world. And it's not, as they told us, oh, you're so pretty because you're tiny. No, we should be ashamed because we're the smallest women in the world because we have been in malnutrition for generations. And this is the result of this kind of malnourished through the years. About education, you can see here the difference between men and women, and especially if you are indigenous women and in rural area, the most common thing is that you won't have any access to education, to health, and you're gonna die younger and with a lot of kids. That is the reality. Up to 80% of indigenous people, in some places, up to 90% live in extreme poverty with only less than $4 a day. Can you imagine this? How does it cost a coffee in Starbucks? Maybe $4, $3. And this is the amount of money that the majority of my people have to live and to feed a whole family, maybe 10 people, 8 people in their family. So this is terrible. And this is the reality of almost half of the world, the south of the world. This is our reality. People are starving to death. A little bit more of reality in Guatemala. How do you say in English? The World Organization, that thing, recommends 23 health workers for every 10,000 people. And Guatemala has 13, one of the lowest in the world and the lowest in Latin America, even worse than Haiti and that all Central America. Almost 26% of our population has no access to basic health care access. So something that is normal in the US, in Europe, Western Europe, is not a reality for us. And half of the women don't have access to quality planning services, family planning services, contraceptives. And this is even worse in indigenous people because of myths, because of different barriers. Hunger. Look at this. This is America, North America, Central America, and South America, and you cannot see another red dot but Guatemala. So we are the worst country in America, and people are literally dying because they don't have anything to eat. Of course, chronic malnutrition, we are the worst country in Latin America, and probably in the world, we're like the 5th worst country. About sexual and reproductive facts, So women start first sexual intercourse at 18 and men at 17. But look at this very interesting thing. Women start at 18, but they give birth at 20. That is the average. So it's very, very common that they start having sex and they get pregnant very, very soon because they don't have education, they don't have access because of religious barriers. They don't want to use anything because that's a sin, but they get pregnant. So it's pretty sad. We have one of the highest rates of adolescent pregnancy in the world. And in my own hands, I have treated girls, 12, 13 years old girls having their babies, giving birth. I even had an 12-year-old girl who died in my hands because she went with a midwife that is not like your midwives. Our midwives some of them, they do not know how to write and read. So they took her with the midwife. She came in the hospital extremely bad. She only gave birth to a dead baby, and then she died in my hands. So adolescent pregnancy is extremely common. 1 in every 3 adolescents is pregnant right now. So it's a huge deal here. About contraceptions, only half of the women using a method are using a modern form of contraception. The rest of them are or not using a method or using something that is not, they're gonna get pregnant. So what do? We travel throughout the country providing services and trying to have a rights-based care. What does this mean? We have to take out those feelings and those thoughts that we have that I know because I'm the doctor or I have the money or whatever, and I know what it's better for you. You should not have more kids. I have to make or perform tubal ligations, and that it's not responsible, that it's not from a rights-based care. People don't have the fault of not knowing about contraception, but we do have the fault of not showing them, of not teaching them, of not providing them information and the quality service. So we try to provide education. We use the TV, we use radio, we use social media. Facebook is our most common and powerful thing to do, to provide services, to provide information so people can come and receive quality services. We have a theory of change that there are a lot of barriers. You can see some of them here. So what should we do? We have to treat them. We have to see every of these barriers and do high impact practice. And the outcomes, these are the outcomes that we are finally trying to reach, to have decreased malnutrition, decreased maternal and infant deaths, because if you don't get pregnant, you will not die because of maternal death. So we truly believe that if we empower, especially women, of course, also men and kids, boys and girls, but if we empower girls and women, we're changing the world. Because if you can empower a man, you're changing his life and you're changing his family probably. But if you empower a woman, you're changing the whole community. So we have to be strategic and we have to be intelligent and use whatever we can do to provide more services, to share more information. So what are our programs? I love this picture. This is one of our nurses. And look at all the women paying attention to her. You know why? Because she is talking in her maternal language, in a Mayan language. We have 22 languages, but it's different if, as a woman, you receive in Spanish the information and you don't understand half of the information. If you receive the information in your language from a woman using your Mayan code, you will probably accept the information much better. So this is part of our strategy to gain the how do you say, the confianza, to gain the, I don't forget the word, the trust of the community. How can you gain the trust of a community? Putting, sorry, Sofía, pues callar a la perrita. Sorry, my dog is barking. So we have to gain the trust of the community. How? With the leaders of the community. Sometimes it's the religious leader, the man from the religious center, whatever, Catholic or evangelic. Sometimes it's the political leader. So we have to start searching which people, which person we have to convince to let us in, to provide services in a better way. So we have a presence in half of the country. Here's a better picture. This is Guatemala, and we have presence in half of the country. How? We have 3 stationary clinics and 4 satellite teams and 3 mobile units. What is this? The stationary clinics, the usual. Satellite teams, this is so much, it is very interesting. We provide 1 nurse, a backpack, and she puts everything that she needs in, and she walks throughout her region providing services. Of course, we have to do promotions, we have to do coordination, but people like to accept someone from her own community. And the mobile units is these little trucks that we put everything in, and we travel providing the same services. We also have some volunteer promoters that are local community leaders. Some are teachers, some are the owner of the pharmacy, or a nurse, or the COCODE, that is like a political representative, and we try to train them every 3 months in something, and they provide short-acting contraception. What is that? Pills, condoms, and injections. In the clinics, we provide exactly the same methods that are IUD, hormonal implants, and with the mobile units, we are able to provide vasectomies and tubal ligations. Cervical cancer is the leading cause of cancer-related death in Guatemala. It's extremely common, and we provide rapid screening of cervical cancer and treatment with cryotherapy. We also have a peer educational program, youth peer educational program. That is, at the end, what we want is these kids to prevent pregnancy, but also to show their friends, their families, their community peers, how to prevent pregnancies and diseases, sexual transmitted diseases. Because youth don't listen to old people like myself. They don't pay attention for us. So we train some leaders, some youth, to share this information, because the youth in their communities are going to listen to them, and it has been incredible, the result. So what has been our impact since 2001? And this is estimated with something called Mary Stubbs International Impact Tube model. We have prevented 300,000 pregnancies, unwanted pregnancies, almost 2,000 infant deaths, and more than 100 maternal deaths. So this is my organization. Thank you very much. I'm gonna leave here. We work almost with 99% of our income is from family and big donors in the US, 1% from Europe. And I can say that we are very responsible to use with wisdom our money. And it's incredible what a small NGO with 52 people can do. Every year we reach almost 25,000 people. And I'm very proud to say not only we provide services, but we provide quality services, because if you don't have money, you should have the same quality services that you will have in the best hospital in Guatemala. So we truly believe that with good education and with strategic coordination, you can reach more people and you can provide services, but I always say to my nurses, with their heart, not only with their hands, but with their hearts and their brain and everything focused. because people deserve to have better world, a better life. And the first step, I truly believe that the first step to improve your life is to stop having kids. Because if you have 10 kids, you have to give. I always use this example with people. If you have 1 pound of beans, this is beans and tortillas, that is corn tortillas. It's the main food that we have. If you have 1 pound of beans and you have 2 kids, you can give a good amount to each kid. If you have 10 kids, every kid it's gonna have only some beans. So we try to change the way we provide education to be more accessible and to be more easy to understand for them, so they can decide, not because I say, I think for you, the idea it's going to be a good idea. No, it's because I explain everything and they're going to say, oh yes, I think I'm going to choose this one because I want a better world and a better life. If I receive this and I'm happy and everything works for me, I'm gonna tell my sister and my cousin and every woman that I have. So this is a role. this is something that can expand. So I think I've already talked too much. We can go now to questions.
Thank you so much, Michelle. It's seriously such a pleasure to hear from you. I don't know if you've seen the chat, but everyone's blowing up because it's just so incredible to hear from you. And we really appreciate your time today. That was a really awesome presentation. So thank you so much. We're now going to move into an audience Q&A, as Michelle just mentioned, and we've been getting some questions in the chat that we're now going to ask. So Ellis asked in the chat, why do Guatemalans have large families? Is it a lack of access to contraception? If so, why doesn't the US send them more contraceptives? Or is it perhaps like a religious issue? What role does Catholicism play here?
I think it's a mix of things. Most of women think that men should decide, and they said, ask my husband or ask my mother-in-law, so sometimes we ask, when was your last period? Ask my mother-in-law. No, you should know your last period. Women are too not empowered. They're so weak, and they have been trained or that they don't have any rights on their body, and everybody has access to opinion to make an opinion, but herself. So if the pastor of the church tell her, it's a sin to use a method, it's a sin to use contraception, oh, okay, they're not gonna use it. And so they have a lot of kids. And there's a lot of sexism. And men, I don't know why, think that if his wife is pregnant, she's not going to cheat. And I just think, if somebody's gonna cheat, she's gonna cheat, pregnant or not pregnant. But it's something that they think. If she's pregnant, she's not going to cheat on me. So it's a mix of things, and a lot of myths. Women think, or everybody thinks, for example, that IUDs are going to be in the front of their kids, and that it's gonna give them cancer, and the tubal ligations are going to make them have menopause earlier than it should. A lot of things that are not true, and it's difficult to. For example, we were going to have a vasectomy clinic like 2 months ago, and there was a church doing a lot of noise in Facebook. Don't perform a vasectomy because it's a sin, and you're gonna have cancer and diabetes and disease of. I forgot the name. A lot of. I was going to say a bad word. Sorry. A lot of things that are not true. So it's a big fight that we have to do, just step by step, patient by patient.
Yeah, thank you so much for speaking to that, Michelle. That obviously is a lot to combat, which makes your work all the more impressive. Our next question is from Miriam. And Miriam's asking, how do our Guatemalan sisters address government corruption, and what government constraints interfere with your work? What can the Biden-Harris administration do to help with pressure?
So we have an MOH, an agreement with the government to let them us use their facilities, because we don't have the money enough to have clinics everywhere. So we have to use how do you say, health centers, and we try to be apolitical. For instance, today it was a huge day in Guatemala with a lot of how to say, protests because of corruption, and we try to stay away because we have to be very careful with our relations, because we need them. Which I try, but for example, we don't accept money from them, because that's a huge deal. If they give money to us, that's corruption, because everything here is corruption. So we're avoiding that.
Okay, thank you. Thank you for sharing that. Our next question is, what does community outreach look like for the youth volunteers? You spoke to them earlier, and we were wondering if you could go more in depth in what that community outreach looks like in that community.
It depends on the community. Some communities can be dangerous. To be honest, we don't go to at least 3 communities because they can kill you if you go in there. But most of the places are very open to receive, especially if we try to be very respectful, and we don't go, hi, we go to the community leader first and receive the permission, and then the doors open. So you have to be very strategic and careful.
Thank you. Our next question is from Noelle. It's a longer question, so I'm just going to read everything she put in the chat. She said, a major issue I see among indigenous communities in Latin American countries, as an indigenous Mexican Colombian youth myself, this is Noelle, is seeing how so many of the young girls and underage girls are impregnated by much older men. What are some of the ways to address this, as it's often accepted as a cultural thing? I've seen this within my own family, so it's devastating that these individuals aren't charged over it.
No. I once saw a girl, she was maybe 10 or 11, and she was giving birth, and I started talking with her. Why did you left your house and go with, because the man was maybe, I don't know, 30 years. Why? And her answer makes me cry, because there was no food in my house, and he offered me food. So that's the level of desperation, the level of she preferred, and she wasn't pregnant before because she didn't have periods yet. So once she started having menstruation, she got pregnant. So this is the reality. By law in Guatemala, we can provide services when they are 14 years old. If they are younger than that, we are not allowed to provide contraceptives, and that's terrible. I understand the law because it's to protect them. If you give contraceptions, is like saying, okay, it's okay to have a sexual abuse, but they are having sex, so it's difficult to handle it. To be honest, sometimes we only put condoms and tell them, use them. Here are the condoms. This is how you use them, but we cannot say that we give them. Once they are 14, we do it. Most of the people in Guatemala, they want to do an exorcism to me because we are providing contraceptions to girls. But the law says if they are 14, we can provide them. The Ministry of Health, even though it is legal to do it, they don't do it. So we try to provide as much as contraception as we can. Some institutions ask for the parents to sign something, even though it is not legal to do that. So we don't ask for anything that shows that she's already 14. So if she tells us that she's 14, we provide. And we don't ask their parents. And if the parents ask us, we say, no, I'm sorry, I cannot tell you anything because it's privacy.
Okay, yeah, that makes sense. Thank you. Thank you for answering that question, Michelle. Our next question is from Hal. Hal said, in East Africa, rural women have little access to education compared to young men. What is it like in Guatemala?
Yeah, it's the same. So it's the south of the world, right? The part of Asia, Africa, and Latin America. It's almost the same. It only changes a little bit the color of our skin, but the suffer is the same.
Thank you. Our next question is from Colette. Colette asks, how does class play a role in healthcare availability in Guatemala? And how does this compare with the US healthcare system? How does class play a role in healthcare availability in Guatemala, like access to healthcare? And how does that compare to healthcare access in the US?
Yeah, I think it's a huge deal because it is very, very different. You cannot compare the access between classes.
Thank you. Our next question is from Melvine, and Melvine asks, what is the policy around comprehensive sexuality education for young people in Guatemala?
So we have in Guatemala, we are known for have beautiful laws. Actually, we have beautiful, beautiful laws, but they're not in practice. So by law, sexual education should be in every school, public school in the country, but it's not happening. Teachers and in public and in private schools. For example, my daughter studying in a private school, and I thought it was going to be very, very, very open. Oh my God, no, the parents don't want the teachers talking anything about sex, and they want to have an exorcism. They want me to have an exorcism. Religion, it's a huge deal, and I can say 9 of every 10 people that I know think that if you talk to youth about sex, they're gonna start having sex. Yeah, and I don't see it changing at least in the next years.
Thank you. Our final question is more about activism generally and reproductive health and rights activism. When we're looking to make big changes, how do we as activists focus on smaller local changes? How do you remain focused and hopeful and just ready to move forward?
I think it has to be related with the size of the institution, because 3 years ago we weren't be able to do any activism because I was doing the surgeries and I was training nurses and I was doing everything in the institution. And now we have hired surgeons and we have hired coordinators that help me. And this has given me the time to go to a lot of things that maybe look like, oh, this is a loss of time, but no, it's important, and we're changing laws, and we're just going to these meetings, these small meetings. We are changing little. We're going to the CNA, that is like the contraceptive reunion of the country, and I brought a question. I'm sorry, but how do you say? Social Security are still asking for the sign of the men to provide 2 allegations to women. And everybody was, what? And they didn't know. So I say, maybe now I can die in peace, because now they're starting an investigation. And if they change that, that's awesome for the country. So just we have to be brave and not be scared of talking. And if anybody hates us for what we are doing, just let's talk. We have to put your heart in it, because I could be in wings training nurses and doing surgeries, but I want more for my country. So it's about passion and about putting your heart in everything. So, and gaining trust and looking for spaces, little spaces, and I get in wherever they let me.
Well, thank you so much, Michelle. It was so incredible to hear from you, and thank you for sharing that. You just speak so well to these issues, and it's such a pleasure to hear you speak. We really, really appreciate your time, and we want to be mindful of your time too. So I know everyone enjoyed that session. That was really incredible. Before we hand off to the next session on population health and environment, I would love it if we could take a photo, as well, a Zoom screenshot is what we're gonna have to do online. Awesome. Well, thank you again so much, Michelle, for speaking with us. We really, really appreciate your time. We're very grateful to have you here. That was a really incredible session. I'm also really grateful to all the audience participation as well. Make sure to keep sending in your questions for the next session. So I'm going to pass it over to Adela.
Hi, everyone. It's me again. Thank you so much for the engaging conversation in the group chat. And then also thank you, Michelle, for engaging and sharing. Now we are going to move to our second guest speaker session on population health and environment. We have around 30 minutes discussion in this session, and we're super thrilled to be joined by Dr. Gladys. So Dr. Gladys, if you could briefly introduce yourself, your work, your background before diving in today, and then you can share your screen and start the conversation with us. I also want to remind everybody that the Q&A session is still keep going. We will ask Dr. Gladys at the end of her session. We also want to give everyone a chance to ask questions to both speakers at the end of the session in general. So please keep sending those great questions in the chat and we'll keep track of them too. So I'll kick it to you, Dr. Gladys.
Thank you so much for inviting me. I wanted to wear the right t-shirt, but I didn't. But I did wear one of the t-shirts, and I've been working with mountain gorillas for quite a long time, like over 25 years. And I started off as a wildlife veterinarian, but along the way, I found that we needed to make the gorillas, reduce the threat of human disease to gorillas. And then I also found that a lot of it was because people had very large families. They couldn't, their family was enough healthcare.
Looks nice. Okay.
Which then resulted in people having to, enter the forest to poach and collect firewood. So family planning then became very integral to our work. And I got to meet Population Connection when I gave a talk at the Wilson Center. And Rebecca came over to Uganda and I spoke at the Capitol Hill Days. So I'm really glad to be here today. And yeah, actually my husband is here where it's quite late at night here, but Lawrence, want to say hello?
Hello team, how are you all?
Yes, he's also here. Yeah, we decided to have 2 children and I'll tell you why. Actually, I'll tell you straight up why we decided to have 2 children. Gorillas are very good at family planning and they only have a baby once every 4 to 5 years, 4.5 years, gorillas and chimpanzees. So we decided to do the same. And we spaced our children 4.5 years apart, which is very logical because by that time the older one can build its own nest and is not depending on the mom and helps to babysit the younger one. And it's really very logical. So whenever I say that in family planning conferences or to a health medical audience, they always laugh because they can't believe that the great apes, the gorillas and chimps are better than them at family planning. But I'll start the presentation here. This is in full. So thank you so much for inviting me for this very important event. And when I came for the Capitol Hill Days, I met a lot of Sierra Club volunteers. And it was interesting that's when it suddenly clicked that Population Connection also is very concerned about the environment. And as much as Population Connection is about enabling women to be able to plan and have the children they want, and at the same time, you also want to make sure that there's not so many people that the planet cannot survive. So it's really great that Sierra Club is also on the other side, but also believes in population. And I was really pleased to get a Sierra Club Earth Care Award in 2018. I'm going to now, I've worked with the mountain gorillas for, as I said, for a very long time. And this is one of my favorite gorillas called Kanyonyi. And he's one of the gorillas that was basically born when I was there in 1996, when I just started my journey working as a first veterinarian for the Wildlife Authority, the government that manages the wildlife in Uganda. And he had an elder sister called Kahara, she was 6 and he was 2 when I had to operate on Kahara. And they used to call her Kahara because she used to like to babysit her little brother, which was really nice. But he eventually grew up to be a big silverback. And by the time I took this photo, he was probably around 18 years old. Unfortunately, he died at the age of 21, not because of human disease, but because of natural causes. He fell off a tree and got a very bad wound in his hip joint, an infection. And then he fought with another gorilla and the infection never healed in the hip joint in spite of antibiotics. He fought with a gorilla that wanted to take over his group and eventually he died. And so it was one of, when he died, you know, so many people were concerned, including the local community, which showed how much people now really cared about gorillas. Because when it was created as a national park, they were suddenly not allowed to enter and they got so resentful and they were even setting their forest on fire. But now they were so appreciative of gorillas because of tourism, which has really transformed their lives. And so Kanyonyi was just a very good example of how far conservation efforts have gone. The mountain gorilla numbers have actually grown quite a lot since I first started working. They've almost doubled in number. There's 2 mountain gorilla populations. There's Bwindi up here and the Virungas. You're probably more familiar with the Virungas because that's where the late Dr. Diane Fossey did her studies in Karisoki. And the famous film Gorillas in the Mist was made about her life. And so most people thought these were the only mountain gorillas. At the time, they thought there were only 300 mountain gorillas. But sometime in the early 90s, suddenly another gorilla population was discovered, in the late 80s actually. And suddenly the numbers doubled. The gorillas in Bwindi were turned out to be mountain gorillas. And that's when gorilla tourism, gorilla habituation began for research and eventually for tourism. But we're really pleased that both populations are growing. Even if they're so tiny, but a lot of efforts are being made. But these 2 areas are surrounded by very high human population density. In Bwindi, it's around 300 people per square kilometer. In the Virungas, it's about 600 people per square kilometer. So it's a very, very high human population density, which really puts the gorillas under pressure. And it means that you can't really expand their habitat as long as people don't have enough land and they have too many children, they're going to keep on the wildlife habitat. And when you get to Bwindi, this is what you find, a very hard edge between the community and the park. And you find that when it became a national park, people are not allowed to enter unless they're coming in for planned activities like for tourism or research or patrolling the park. But the gorillas sometimes come out because once they lose their fear of people, they start to roam where they used to go before, you know, before their whole forest habitat was destroyed. So habitat loss is a big problem all over Africa, not just Uganda. Gorillas are found in 10 countries in Africa, and almost all of them have this issue of habitat loss. But poaching is another issue. You've just had a power cut, but it's okay, you can hear me. Poaching is another big issue. It's not so much for, poaching is not so much for the gorillas, but it's because people in Uganda don't eat gorillas meat, thankfully, but in other parts of Africa they do. It's more for other antelope like Daika bush pig, and they get caught in snares and they get speared, which unfortunately happened during the COVID pandemic. So one of the big issues, because there's such a hard edge due to high human population growth, is human wildlife conflict, where you know, gorillas go and they eat people's banana plants, as you can see, and this has led to disease transmission. So one of the very first cases I had to deal with in Bwindi in 1996, when I got my first job out of vet school, setting up the veterinary department in the Uganda Wildlife Authority, was a scabies skin disease in the mountain gorillas. This baby gorilla died, unfortunately, and the rest only recovered with treatment of ivermectin. Actually, it's interesting, it's being used a lot now for COVID, but at that time we used it to treat scabies. And eventually we found out that it came from people living around the park who have very little healthcare and very little hygiene. Because you can see these little boys are supposed to be in school, but they were herding goats outside the park. And as long as they can't end up going to school, you can't break that poverty cycle. And this happens a lot because they come from very large families. So the view you get when you come to CTPH is we have one of the best views of the forest, but this is the whole of the Bwindi forest, almost. It's only 330 square kilometers. And we keep gorillas healthy and their habitats secure. And generally we promote conservation by enabling people to coexist with gorillas and other wildlife by improving their health and the community livelihoods. And our vision is for people, wildlife, and livestock to live together in balance, health, and harmony, with local communities acting as stewards of their environment. So we have 3 integrated programs: wildlife conservation, community health, and alternative livelihoods. And within all of this is where we have our PHE approach, population health and environment approach. Actually, just to go back to the wildlife conservation and wildlife health, is more like we analyze samples. We basically carry out gorilla health monitoring, and we compare what they could be sharing with the people and the livestock. And then we try and prevent disease transmission between the 3, so zoonotic disease transmission. And with community health, we work with village health and conservation teams, and some of them promote family planning. And then with alternative livelihoods, we started a gorilla conservation coffee social enterprise, where actually, you can see over here, this is a sleeve of the coffee, and we're really pleased that Population Connection served it to some of the donors a few years ago. But the photograph is actually, this coffee was named after Kanyonyi, my favorite gorilla, who I showed in the photo, who unfortunately died in 2017. And we found that we had to do it because a lot of people are unhealthy because they were poor. And this was one way of engaging them and stopping them going into the forest to poach. So we train village health and conservation teams. In Uganda, we call community health workers village health teams. But because we started this whole system of training them to do conservation work, because they could actually reach people's homes much more effectively than conservation communities were trying to reach people, but they were not managing. So we decided to start training them, and it's just amazing that half of them happen to be men and half of them happen to be women. A few years when we had just begun, like 1 or 2 years in, there's a lady here called Dr. Lynn Gaffikin, who was a PhD fellow in Madagascar and worked with a lot of big conservation NGOs, and she came in to help us to set up the PhD program. This is the government health center where women can go for family planning, except that very often when they arrive, they find a very overworked midwife. And even if they're just coming for an injection, she may end up not giving it to them because the midwife and the nurses are overworked dealing with very sick people, and they won't give them the injection, and then the women will go home and conceive. Because typically we found that they will tell their husbands they want to go on market day, and then they'll quietly get a contraceptive, an injection. It was more favorable to the pill because, you know, they could throw away the pills into the toilet, the pit latrine. And so, and a lot of women want babies that they didn't want to have because they couldn't control their fertility, just because they didn't have access to family planning. And also because there were so many myths, and they would end up going back to family planning again. They'll go back to having babies again. So we took this photo right 1 or 2 years into the beginning of the program. And this lady called Hope, we were very happy that through our approach of getting them to talk to people about family planning, that women became very empowered. So we really reduced gender disparities. This is a community where a lot of girls are teenagers. I mean, a lot of girls, you know, are mothers, a lot of teenagers. You know, when we got funding from USAID through their population office, they said to me that you have to select one, you know, education method. Should it be couples, women, men, or youth? And I thought to myself, the youth in the community, the girls are all married by the age of 15. Barely any girl who's not married. So maybe we should focus on couples, because if the fact that they don't talk to each other is the reason why they're not really adopting family planning. And one of the very first people we hired was from the local community. She's a lady called Vasta, whose father had the foresight to educate her. He was a senior traditional healer in the area. And because of tourism, she took a degree in tourism, so we hired her. And she was one of the people who helped to get this program going. And Vasta had her first child at the age of 25. And by the age of, in her lifetime, she's had like 4 children. At the age of 25, they have 5 kids. By the age of 36, you've got 10 kids. And they're looking really old because they're just having babies every year. So we basically, these are the kind of families you get. Almost everyone is the same age, and this is very typical. So this is one of our volunteers who's talking to them. We find that actually having men in the program is very helpful because they can convince the men about balancing the family budget, and they help their wives, they support their wives to get onto family planning. But we promote hygiene and sanitation. We look out for people who are sick, and voluntary family planning is a very big component of our work. Nutrition, sustainable agriculture, report homes visited by gorillas, and talk about zoonotic disease, why it's important not to, and why it's important to, how to get benefit tourism. And this is Vera. This lady is actually giving, one of our volunteers giving a family planning injection. And we found out within a year that this is the most popular contraceptive because you can quietly get it without anyone knowing. And yet, because they go to the hospitals and they end up not getting their shot because they're dealing with very sick children and overworked nurses and midwives, they end up conceiving. So when we were able to bring it closer to them, they just go to the next door neighbor, they get the shot, and then they're really happy. And so this has really helped. This helped to double the family planning, and it's really been embraced. So Family Health International were promoting this method as a pilot study. We became their 5th site, and this eventually became adopted all over Uganda. I went to that research to policy engagement, which was amazing. Unfortunately, the champion who they got to adopt it actually died, a few days ago, which is very, very sad, Dr. Mbonye. He was a real PhD champion because he loved what we were doing. He really got sold on to promoting family planning to protect wildlife, and he just loved everything that we were doing. So the impact of our work is that we've contributed to the growth in the gorilla population, the mountain gorilla population, since we started working in CTPH in 2003. And I actually participated in the first gorilla census when I was a veterinarian working as a vet in the Wildlife Authority in 1998 as their first vet. And so we're really pleased that the numbers are going up. We're really hoping that they'll continue to go up. And some of the impacts we've seen is that gorillas are now protected in community land. We've had a very big fold increase in hand washing stations, which has resulted in reduced disease outbreaks like scabies and giardia. We've had a very big increase of women in family planning, where we're above the national average because of our approach. So we started off at 22% of women, which is less than the national average in rural areas. And now we're above the national average. 67% of where we're working on family planning, and them have started businesses, because they don't have to have a baby every year. And one of our best testimonies, a lady who's had 3 children and 3 tried for a boy after our volunteers came to talk to her. And that was amazing because she owns a shop, and those 3 girls are going to have the best education and the best life. And they're also not, when they become mothers, they're just probably going to have few children because of the good example they've had from their mother. And so we're really pleased that women are more involved in conservation and men in family planning as a result of our program. That was an unintended outcome, but we're really pleased that it happened because it's really helped to amplify and enrich our approach to integrating conservation and public health to have a more balanced planet. And I'll end off by saying that these same volunteers have been promoting COVID prevention in the communities. We've had so many activities. And the latest right now is on top of giving out these posters on telling people to follow the SOPs, they started telling people to get vaccinated. And now the latest is because we've just been going through a very severe second wave. And it's resulted in the Ministry of Health asked CTPH to help because we're a conservation NGO sitting on the task force. They asked us to help to set up village COVID task forces, of which there's a Uganda Wildlife Authority, the porters, the village health and conservation teams, the religious leaders, and they are all working together to prevent COVID and strengthening home-based care because there's hardly any space in hospitals, if at all, for people who are very severely ill. And these same people are also promoting family planning in the villages. They're really embracing family planning. So we're very pleased that it's brought people together. For more information about our work, please visit the website and follow us on Facebook and Twitter. And buy some coffee in America. It's available in America. You can find it on the website and also on gccoffee.us, gccoffeeus.com. Thank you so much, Population Connection. And we hope you guys, all of you can come to visit us in Uganda, like Rebecca did, and a few other staff at Population Connection. Hopefully we'll get John over one day.
Thank you so much, Dr. Gladys. It's such a pleasure to have you here today. We would just want to thank you for sharing, and thank you for all those super important on the ground community work that empower the community. I also want to encourage people to keep sending in questions in the chat for Dr. Gladys. We will collect them too. Okay, so we'll get started with the first questions that we received. Before going to the audience question, I want to use a little bit of power as the co-host to ask a personal question. So I had the pleasure to read your very important research on disease control in local communities. And since we're talking about the Global Heart Act, the Global Gag Rule, I'm wondering, how did the Trump's Global Gag Rule impact programs in your local community in Uganda to prevent other global health issues like HIV, AIDS disease, etc.?
Yes, it really affected us because a lot of we were actually getting free contraceptives in the Obama administration, and then when Trump administration came along, we were not, there was much less provision of family planning supplies and much less supportive atmosphere for all the things that the previous administration had really supported. So yes, it really did affect us a lot in Uganda. A lot of the organizations were struggling to raise money for family planning commodities. I mean, we've worked in DR, we also have a program in DRC, and they've embraced family planning because they saw it as a way to reduce poverty in their homes, as much as it's a very largely Catholic country, but they don't even have free access to family planning. At least in Uganda, you do. So it just made it more difficult all over the world to really promote, to enable women to have access to family planning. Yeah.
Thank you so much for sharing.
We're really pleased for the Biden administration. Like, we're pretty much having sleepless nights during the election time and the counting and everything, just like I'm sure most of you are.
We were having an active issue. Thank you so much for sharing. And we also got a question from the audience Q&A. So it's a rather long question. I'm just gonna read everything. In the 1970s, I started study of the chimpanzee families and organization in the Gombe National Park, Tanzania, for a doctorate at Stanford University. When I compared air photos from the RAF in the 40s versus the 60s, it was clear how human population had removed forest for agricultural activities, thus limiting range. This habitat destruction has continued into the 21st century. I saw then and believed that the education of women and their choice would promote private conservation. Is that also true in Uganda and Rwanda?
Yes, it definitely is true. It really is true. Like, just like I gave the example of the very first person we hired, the fact that her father, made sure she went to school and not a big difference. And so, yeah, so it really makes a difference educating the girl child. It really does. I remember, like, when we started doing health education to the communities in my last year, working as the first vet for the Wildlife Authority, I was leading a team of men, and I could hear the women whispering, "Oh, we need to educate our girl child." So I was glad that I provided some inspiration for them. And I think it's really, really important, because once somebody has gone to school, they're not going to rush to have a baby. And that Vasta has, it halved the number of children she had just because she went to school. So yes, it really makes a big difference. Actually, one thing I forgot to say in my presentation is I'm writing a book, of which Population Connections is also supported, about my conservation journey with gorillas and other wild, meeting somebody like that who's a live example of how education has really helped, and access to family planning has really helped.
Thank you so much for sharing. And Dr. Gladys, I just want to remind that you froze a little bit in the process, so feel free to adjust your Wi-Fi connection if that could help. Okay, we are going to move to our second question from the audience. So what do you think are the most critical barriers to any PhD programs population health and environment around the globe? And how has conservation through public health countered those barriers?
That's yeah, very good question, I have to say. We're still trying to counter those barriers. But I think one of the biggest barriers has been fundraising, because all the donors think in a single sector approach. So, you know, the health donors, when you talk to them, they're like, but you're animal people. And then when you go to the animal donors, they say that's public health. And PHE basically touches all three. So it's very hard to find a donor who understands that a multi-sectoral approach is the most holistic way forward. And so I've had to get involved in a lot of advocacy. I love being out in the field, but I had to find that I'm giving presentations, going around the world, just trying to tell people, the donors and people out there, the government as well, that we really have to integrate everything if we're going to have long-term outcomes. So fundraising has been a big one. We've tried to overcome it through advocacy. But one thing we have found is that at the community level, people really embrace PHE because they don't have one problem at a time. Everything happens at once for them. And so when PHE is able to address all their problems at once, and so we are showing a lot of examples how it's making a big difference in the communities. And whenever I talk to like government stakeholders and people like that, and I talk about the work we're doing in the community, they get very excited and they're like, wow, we need to scale this up in other places. But if they see the communities are benefiting and they're embracing it, then sometimes it has to be a bottom-up approach for people to understand PHE. But I can say in Uganda, the conservation community has probably embraced it much more, because the national parks are all surrounded by high density of people, and people keep agitating the government to degazette the park and reduce its status so that they can encroach on the land and take it. And so right at the highest level to the Minister of Tourism, they're always talking about, you know, we really need to address this issue of having too many people, you know, very high human population growth rate around the protected areas. So yeah, it's been a bit like that. But I have to say that COVID has helped the health sector to understand that the environment is important as well. And both sectors are realizing they have to work together to have a better future, a more secure future.
So well put, Dr. Gladys. Thank you for this response. And you also mentioned like local communities embracing new ideals and modern contraceptions, etc., which transitions smoothly to our last question from Hannah about what are some of the cultural and social barriers to contraception for women in Uganda? How have you been able to involve men in the conversation and help?
Yep, we've really involved men in the conversation. One thing that we found at CTPH, that couple peer education was the best way forward for us, because if domestic violence was a big problem, you know, husband's going to beat his wife because she's not having babies, or he'll go and marry another wife who's going to have babies. And so the situation just gets worse for the children and for the family. And then the woman's like, okay, let me just stop taking contraceptive because I don't want my husband to leave me. So there's been a lot of that. So getting couples to talk to each other and realizing that it's a great idea to have the children we can manage, because we reduce poverty in the home, we'll balance the family budget better, they'll go to school, they'll get jobs, they can look after us in our old age, and we break the poverty cycle. So it's all of that whole thing. And a lot of times people thought that the more children you have, the wealthier you are. But slowly people are beginning to realize it's actually the exact opposite. And, you know, for example, when we developed some flip charts, I think I showed a lady holding a flip chart. We took it back to our volunteers, the community and conservation health volunteers, and said to them, what do you think? And they said, yeah, because, you know, in our communities, people fight over land because they have so many children, and even siblings can end up even killing each other for land because there's so many of them. And there's only limited land that they've inherited. And so it became something that everybody felt was the best way forward. And I have to say that Mungu district, where we are, we have one of the lowest, like 4.7. When I said it's 4.1. And the person who, in one of our meetings, he really praised us.
You froze
saying
a little
that
bit.
CTPH has really helped to reduce the moment we started the organization, when we held our first workshop in 2003 to tell the stakeholders that we started this new organization. Those are two very controversial issues. And with the PHE approach, we're able to approach them well, because we tell people that we care about their health. We don't just care about the wildlife and the trees, And family planning is here to make sure that women have a better, they have more control over their body, they have better maternal health, the children have better health, and it's better for your well-being because you're balancing the family budget. So just bringing how you package the information is very, very important. That's something that we've learned along the way as well. I hope I've answered the question.
Thank you so much, Dr. Gladys, for this fantastic discussion and Q&A on the intersectionality between population, health, and environment. We also appreciate your crucial on-the-ground conservation, family planning, and disease control efforts. Such great work, and you're such a great inspiration to me, and I think to all of us too. Before we kick the session to the final actionable item, we can do a brief Q&A with both speakers since Michelle hasn't left yet. If y'all have any last minute question, some final concerns or ideas or anything that you want to chat about to both speakers, please take your time to write in the chat box. We're also collecting unanswered questions from the previous two sessions. So Isabel, I'll kick it over to you.
Awesome. So thank you so much to both of our speakers. Yeah, as Della just said, we have more questions. Gladys, it was so great to hear from you. I really love learning more about the intersection between population health and environment. So I really appreciate you speaking to that. Michelle, if Michelle is still here too, I have two more questions that we can direct to both of you. Okay, so our last two questions, Gladys and Michelle. Gladys, you can go first, and Michelle, then we will pass it over to you. This question was from Delicia, she put it in the chat earlier. Are there regional collaborations among advocate groups and/or community organizations that you are a part of to elevate reproductive rights and health? Gladys, if you'd like to go first.
Sorry, what did you say? You said, are there regional organizations?
Yeah, regional collaborations among like different advocate groups and/or like community organizations that work to promote reproductive health and rights.
Yes, there is. There are a number in Uganda amongst the health community, and also we're working with other countries. So in the East African community, there is Uganda, Kenya, Tanzania, Rwanda, Burundi, and South Sudan rejoined recently. So they really liked the PHE approach, and when we talked to them about what we're doing in WINDI, I helped them to develop a PHE strategy. And now we have the national PHE networks in all those countries. So the government has really embraced it, and it was a successful advocacy effort between CTPH and other NGOs, including big groups like IUCN, FHI, 360, but also Straight Talk, who focus a lot on teenagers, and youth, and sexual reproductive issues in teenagers and youth, and that was Straight Talk Uganda. So we all got together, and we used to have a PHE working group. There's also Ecological Christian Organization, but now the government took it up, which we're great to see. They still come and learn more about PHE from visiting us. But yes, we've teamed up with other organizations in the country, and they're all embracing the whole issue of integrating family planning, health, and the environment.
Awesome. Thank you so much for answering that question, Gladys. Michelle, if you'd like to go ahead, and I can repeat the question too, if that's helpful.
Yeah, thank you. I think that we have to work with other people because we are not strong enough, especially financially. So we cannot have a clinic in every part of the country. Our biggest society is with the government. We have to work every day with the government, with the health program and educational program too, and also with local leaders in every place we go. So yes, we are stronger when we work together. By our own, with our own strength, we wouldn't be able to provide the same amount of services.
Thank you, Michelle. Thank you for speaking to that. Our second question of the night is, how does wealth influence access to reproductive health care? Again, Gladys, if you would like to start, and then we can pass it to Michelle.
Yes, I would say that it does very much so, because with wealth, you can take your kids to better schools, people can go to better schools, and when people are wealthy, generally they make sure that children get educated early. And so the girls benefit a lot because they'll get education when they're young, and they're much less likely to have teenage pregnancies, or much less likely to, once they've got their degree, when they get to that level, they don't want to just rush and have children out of high school. And the longer they delay to have a child, then the fewer children they'll have, and those children will have a better life. So wealth definitely influences a lot. People who are very poor just don't have much opportunity, and they get exploited. Like I had Michelle saying, that girl who got exploited and got pregnant because she had no money. And those things kind of happen a lot when you don't have money. And poor families even just sell off, I wouldn't say sell off, but they marry off their children young because they just don't know what to do, which is also very, very sad. What you call child marriages is a very big problem as well. So all of that is to do with education and wealth. And so, yeah, but I think the biggest way to break out of that whole thing is education and having the children you can manage, so then you can actually find a way of getting them to school. And very, very important to educate the girl child, because that's where all the issues start to come about.
And from my end, I think that from the very obvious thing, if you have money, you can pay for a service. You go with the doctor that you want, and you receive whatever you want, and you receive information. You have access to internet. You have access to better education. You have a car to ride into the doctor's office. If you don't have money, you don't even have money to pay for the bus to go to a service. You don't have money to pay somebody to take care of your children, to go to a visit to a health center. And in the more non-obvious way, for example, abortion is not legal in Guatemala. So if I know a lot of people that have paid for the girls that are pregnant. They take them to the US or to whatever where they can provide an abortion, and that it's not a reality for poor people. They don't have access to abortion, so they just have kids and with no other possibilities. Some of them just commit suicide. Some of them just have a very bad life for the rest of their lives. So yes, money, it's a big deal.
Thank you to both of you for answering that question. That was so well said, so thank you. Our last audience question of the night is from Hal. And Hal asked, to what extent might climate change be a background to northern migration in Africa to Europe and South America, to northern migration in Africa to Europe and South America to North America? Gladys, again, if you'd like to start.
Let me see. Christian. I think to a certain extent, so much into it, but for sure the weather is changing. For example, the place where the gorillas are, people never used to have malaria, and now they do. And I think there's been a slight increase in temperature. And so, and because of that, the insects, that the mosquitoes are more active, the malaria mosquitoes are surviving, and some diseases are coming up because of climate change. And then it's making people move away from the area. I would say that it's been more a case of moving within the country as opposed to moving from Uganda to another country or from Africa to another continent. I think it's been more like people moving from rural areas to urban areas, or moving to different places around the country, because wherever they are, things are getting harder. And so, yeah, it's something I have not really studied or looked into, but for sure, climate change is definitely affecting, migration, I think, to a certain extent. Definitely affects animal migration.
In my case, I can see two things. First of all, we are an agricultural country. So if you don't have rain, you don't have food, and you starve to death. So even families have more kids to have more hands to work in their land. And if there's no rain, they don't have anything to eat. So what happens is we have a lot of towns where there's no men, only women and kids, because the man of the family have to leave and go to the States, even if they don't speak even Spanish or English, but Mayan language, to feed their family. And the other thing is that hurricanes are very rare in Guatemala, so we don't have a good infrastructure. And just last year we had 2 hurricanes, not very strong, but it was a mess. So a lot of people and a lot of little towns lost everything. They don't have anything to wear, to eat, to live. So a lot of people needed to go to the States because it's the only way of living. There's no jobs in Guatemala. There are no opportunities in Guatemala for them. So yes, climate change, it's a huge part of the problem. But I think the biggest part, I have to say, it's violence. The majority of people that leave the country, it's because they are afraid of being killed by gangs. And that's the biggest reason why people leave. But yes, also for environment and environmental changes.
Thank you so much to both of you for answering those last minute questions. And I also hope that you all enjoyed hearing from our incredible speakers and had a wonderful time in those 2 sessions, just as we did. I also want to suggest giving both brilliant speakers a virtual clap through the Zoom session to appreciate their time, their effort, and them sharing those great information and work that they've done in the past. So thank you again to both Michelle and Gladys. And we are near the close of our session, but we do want to end this with a last action of the night. So I'm now going to pass it over to Ajua, another one of our awesome Some of Her Lead fellows, to tell you all about our final action for the night.
Hello, everyone. My name is Ajwa, and as Adela mentioned earlier, we had a big win last night with the House passing the Global Hair Act, language and appropriations. We are now focusing on the Senate, who will be looking to pass appropriations bill this fall. So please sign up now to be a Fight for Her leader this fall to demand that the Senate ensure reproductive health rights for everyone, everywhere, and by passing the Global Hair Act through appropriations. We hope you will join us in this fight, and we appreciate you so much for being here. Thank you.
Thank you so much, Ajua, for speaking that. Isabel also just sent the link of Fight for Her Leader registration in the chat. So if you're interested, please feel free to open the link, see what this is about. And this is like the first registration link we have. We will have more information in the follow-up email later. And before we officially end our session, I want to try again with Representative Ami Bera's video. I'm going to try this time with my computer. Please bear with us for the technical difficulty. And if we still fail, we apologize and we'll send the link to you all after this event. So
I'm Congressman Ami Bera from California's 7th Congressional District. I'm also a physician and a longtime advocate for a full repeal of the global gag rule. It's been my pleasure to work very closely with Congresswoman Barbara Lee as we've introduced the Global Hair Act in this Congress. You know, this is an important week for us because in the House Foreign Operations budget bill that we will vote on, I believe tomorrow, we include the full legislation of the Global Hair Act, which would permanently repeal the global gag rule. It's an important first step to get this piece of legislation passed in the House of Representatives. We've got to work ahead of us in the Senate, but at least this is a first step. The reason why it's so important to fully repeal the global gag rule is it stops progress for women and girls around the world. The one thing we can do if we want to help empower women and girls is to give them full power over their own reproductive health options, over their own bodies. Nothing could be more personal than that. And I say that, you know, as a father of a daughter. I want to thank all the advocates at the HER Summit for all of your grassroots hard work. We still got work ahead of us. So if we pass this legislation tomorrow out of the House, Let's go to work and let's get the Senate to do the right thing and send this bill to the president's desk. Thank you for all your advocacy. Let's keep up the hard work and the grassroots work. And again, be kind to one another, be safe, and be well. Thank you.
Awesome. Thank you, Adela. You were magical. Thank you for getting that to play. That was so great to hear that. And we will be sending that out in the follow-up email too, for those of you, or for those people who had to leave already and didn't get to see it. But yeah, really awesome. Actually, the vote he's mentioning actually happened last night, which Adela, of course, already touched on, that language for the Global Her Act already passed in the House. So just as Adjoa mentioned, sign up to be a Fight for Her leader in the fall, and we're really going to push the Senate to do the same. But I just want to wrap up tonight. Thank you all so much for being here, and thank you to our amazing speakers for their time tonight. It was so great to hear from both of you, Gladys and Michelle. It was so great to see all your faces, even if only over Zoom. And I also want to say a big thank you to all of our Summer of Her fellows who made the Summer of Her program so special this year. Thank you for all of your hard work and your engagement. We will be following up tonight with an email linking all of our actionable items from tonight, as well as Ami Bera's video. So if you missed anything or you want to encourage your network to get engaged as well, those are all going to be accessible to you. We really hope you all enjoyed tonight. Thank you for bearing with us through the technical issues. But we all hope that you are inspired to continue to take action to fight for her and end the global gag rule. Thank you so much for joining us, and we really hope you have a great night.
Thank you too. Thank you so much. Thank you so much, Isabella and everyone.
Thank you, Gladys.